doctors were fearful of prescribing opioids. I know a lot of primary who basically stopped cold turkey. Some pain management left, downsized, and unfortunately, without proper education and communication, many of these patients go to the street. And you see fentanyl is on the rise since 2013, and that's the main killer, okay? And it's mostly non-prescribed. Again, I want you to understand me correctly. There are problems with prescriptions, right? Prescriptions need to be monitored, maybe reduced. There were issues mostly 10, 15 years ago with some pain practices here in Ohio. That's absolutely a medical fact. Having said that, the situation is changing, and I'm not sure the policymakers and regulators really are following up about what's going on. Let's go forward. And that's what we see. You know, in 2009, the opioid death rate in Ohio was more or less average in the United States, which is still not good, but it was average. Now, since 2009, 10, 11, the more regulations are being passed, as that you can see, the more this media, I don't want to use which kind for pain management is going on, the more and more people dying. Because the regulations don't change people's mentality. You need treatment, you need to develop addiction services, you need to establish opioid task forces and fish tanks. There are some, but just by regulating, by scaring, by putting bureaucrats and policemen, you're unfortunately not solving this problem. And the more you do it, the worse it becomes. It's very clear. And this is CDC data. Just let's move forward. And we actually ran into a lot of issues with HMOs. Let me just mention CareSource, which is this is the letter from about 15 US senators to CareSource, basically saying, what are you guys doing denying access to care for vulnerable patients? Let's move forward. It's available as part of my article that you can find on my website that we recently published. I don't want to spend time. You can look through it. Let's just move forward. There are a lot of names here you may or may not recognize. So it's not only crazy me who raises this issue. It's pretty obvious, but unfortunately the solution has not been found. Let's move forward. And this is our experience. It's around the same time we got complaints about CareSource. Let's move forward. Blocking access to care. Blocking access to care. Sorry for the quality. Let's move forward. That's another one. I had like 30 of them I sent to CareSource around that type of number, and I submitted business integrity complaints. Let's move forward. And the result was denial of services. There's a EOB for specific patients denied, and I have like hundreds of these pages. And honestly, everybody says, wow, but unfortunately, not a lot is being done. Let's move forward. Now, the same population is at risk for coronavirus infection. Minorities disproportionately higher risk, and we see it in everyday life. Let's move forward. We recently published this article in collaboration with Cleveland Clinic, reviewing our charts. And our point is that screening and brief intervention, as well as appropriate urine drug screen testing, minimally invasive procedures, documenting organic pathology such as with electromyography. It has documented statistically significant impact on pain reduction and functional improvement. And I think that's the way to go. And I hope it will be heard. At least that's our experience. And we followed 155 patients over 2 years. So it's 23-page article, mostly based on Ohio data. All right, let's move forward. And we feel, basically it needs to be supported. There is statistical significance. There is slight variation of how you can screen patients, but screening and early intervention is the key to go. Let's move forward. This is the part of the study. We followed ABP-MNR guidelines, okay, and we developed certain set protocol. Let's move forward. We use simple tools like this PET tool, which is available since '03. It helps you to document functional improvement, activities of daily living, analgesia. It is, to some extent, self-report tool, but it's very inexpensive and validated, so we use that. Let's move forward, as well as other tools. And we basically set pain reduction as moderate, 30 to 50%, which is more or less the pain societies recommend, about 50% significant, about 70% very significant. Move forward. We also monitored functional improvement. Let's move forward. And we worked with American Board of PM&R. Let's move forward. And we found significant functional improvement. Okay, and as time goes by, you see in 2 years, there were 20 patients with very significant improvement versus 6 then less than 2 years. It's only part of the analysis. And again, if you want the full data, it's in the article. Let's move forward. And this is percentage-wise, same point. Let's move forward. This is chi-square we implemented just to show we've done decent statistical analysis. Let's move forward. Same true about pain reduction. There is substantial pain reduction, and I intentionally put pain reduction after functional improvement because I think functional improvement is more important, but pain reduction obviously is important too. Let's move forward. And this is percentage-wise over time. And again, it's statistically significant. Let's move forward. This is the summary, right? So at least moderate pain reduction, 72.2%. I think it speaks for itself. Let's move forward. And this is our patient, I think the key is to building rapport. A lot of time, we found that lack of communication or lack of proper assessments, and we spend time, that's why screening brief intervention is important, can solve a lot of problems. I worked for different hospitals for a while, and I know how things are. And I know sometimes people don't have time to talk, even good people who would otherwise want to do that, but nevertheless, sometimes you need time. You need time, and you need, our belief is that you need a good protocol and you need to follow it. You don't want to cut corners. And sometimes you discover amazing things. And when you put different validated assessments as well as input from the lab and pain psychology, you can find way to help people who were labeled as difficult or non-compliant in the past. Let's move forward. Yeah, and that's, if you build rapport with a service dog, I always say you build rapport with the patient. Let's move forward. This is SOPAR. This is an example why it's so tricky. It's definitely a good screening tool. It's validated, good risk certification. Let's move forward. However, this means, in my experience, that there is a patient who Googled it before the visit. And that's why, he's trying to get, or he or she, the lowest possible score. And if you talk to them, never got angry, never got bored in his life, that means, something is not right. And you need to have experience, you need to be aware. And that's the problem with a lot of assessments. And again, that's why you need to have multi-specialty program with pain psychologist, with pharmacology doctor, with experienced team to interpret it. computer cannot do that. Let's move forward. Yeah, a lot of, if you ask primaries and even in lay community, urine drug screen, regulatory agencies, urine drug screen, it's definitely objective data, but it also has issues. Let's move forward. This is classic what you see in Ohio. It's fentanyl. Remember, that's the killer we discussed in the beginning. Unprescribed fentanyl, alcohol, and prescribed or unprescribed oxycodone. And sometimes benzos. You don't see benzos here, but sometimes it goes together with benzos, and this is deadly combination. It means the person is in a pretty severe risk. Let's move forward. Yeah, this is obvious. This is alcohol. This is clear cut. Let's move forward. This is, though, tricky. It's ethyl sulfate, right? It's specific to alcohol. Yeah, I hear some background. Yeah, we touched on alcohol. Yeah, so basically, the question is always, is it real? Yeah, is it real? Is it really drinking? Is it remote drinking? Can it come for low, let's say for NyQuil or some kind of toothbrush with low alcohol content? And it's a judgment call, because, you know, if you miss it and you give opioids to somebody who drinks, they can die. But if you unjustly stop opioids on somebody who needs them, they can go through withdrawal and they go to the street and buy stuff. Let's move forward. Yeah, this is also very common, and just I wish somebody showed that to me when I was a student, so I'm showing it to you. It's very typical, you know, well, person is on Percocet and urine screen is positive for oxycodone, so it sounds great. The only problem is there are no metabolites. No metabolites. As you know, oxycodone is going through your digestive system, first pass and so on, and it's metabolized to noroxycodone. So you see here, there are no metabolites, and the levels are sky high. And the only way you can achieve it if you actually drop oxycodone powder in the urine cup. And some patients, you know, Google it. Unfortunately, all these tricks are on YouTube or, you know, online. So you need to have experience interpreting urine screen, because this is basically failed urine screen, and you need to refer patient to addiction medicine evaluation. Next slide. Yeah, this one is interesting. It's nothing there, but I think at the bottom, if you can see, I think it says diluted. You know, comment, it says diluted. It's a little bit hard for me to see, but that means that a person added water to the urine screen. Let's move forward. And it's not worth anything. And this is the same person from oral fluid. And you see he is positive for benzos, for THC, and I think unprescribed hydrocodone. So that's why they diluted the urine. But again, if you just look at the screen, you can miss it. Let's move forward. So basically, the bottom line, urine drug screen is a great tool, but it also needs to be taken with a grain of salt, and you need to know how to interpret it and correlate with the clinical picture. Now, another problem what we face is, you know, primarily during COVID and even before, is the issue of violent threats towards pain practitioners. You know, mostly I think it's sometimes for people who really have opioid or substance use disorder, what used to be called addiction in the past, but sometimes people who made it a business, who divert medications, when they're exposed primarily with evidence that's hard to deny, like this urine screens, they can be pretty violent. They can be verbally or even physically. Let's move forward. That's our staff card. Let's move forward. This is stuff thrown at stuff, at our, you know, the thermos thrown at stuff, hinges broken. Let's move forward. Yeah, let's move forward. Somehow they're able to get my cell phone and see there are non-stop phone calls. Let's move forward. And just to give you a sense, this person who made those calls, because I can't tell you more, but we discovered that he obtained close to 2,000 oxycodone pills over 4 months from 6 providers, which was obviously not for his consumption, right? He would not be around had he consumed it. So obviously somebody else was consuming it. He was, I assume, diverting it, and he got it, that we know that. So he tried to basically harass us over the phone, and then interestingly, we didn't give in, so he complained that we wrongfully discharged him after discovering that he obtained all these pills. And to our amazement, the regulatory agencies had no concern that maybe it's not a good faith complaint, and eventually we closed it, but just to show you what environment we operate in. Let's just move forward. Yeah, and this is, it doesn't happen all the time, but you know, people get out of control as well. And we don't have a guard, and it's just a pretty tough environment. Let's move forward. And that's what we told the authorities, that, you know, we don't have funds, unfortunately, and denials of services play a role in that. Let's move forward. So these are pain management best practices. Okay, I think it's a very good document. I do recommend anyone to look through it, and we try to model our protocol based on this. Let's move forward. That's the protocol we have. It's a very loaded slide. You can get it, but basically the idea is to have several assessments and to use experts from different specialties. Let's move forward. I know we're short on time. Now, it's getting worse during the pandemic. There are special requirements with special precautions. And, you know, we were partial lockdown, and at some point we opened up. And we did see several patients confirmed. There is a concern, and we try to deal with that. Let's move forward. Well, we did receive some assistance as general, you know, as any business, I would say, but I think more can be done. Let's move forward. We also prepare video materials for patients. It took me some time to understand that some patients have hard time understanding reading materials because of educational and other challenges. So we have video materials. Let's move forward. And we have non-commercial YouTube channel for our patients. Today, everybody has a smartphone, so we try to educate patients this way, even though it seems like most people who watch it now are not our patients, beyond our patients. Let's move forward. So we're sometimes in a catch-22, and that's kind of, I don't want to say game, but the situation we need to deal with. We're required or expected to do tests by the state and national authorities, fighting with insurance companies to get them approved or facing denials. Let's move forward. And we constantly face decisionary recommendations made based on financial objectives and not on evidence, and non-physicians dictating physicians how to practice. If a big HMO drops a code, then it's too bad. It's basically tells you what to do, what not to do, no matter what anybody says. Let's move forward. This is some input we got from experts. Let's move forward. And this is very important. This is Fivepoint strategy from 2017. Just Google it. I think it's a very important document. Let's move forward. Next, yeah, good. So see, one of the points that nationally advocated advanced the practice of pain management to enable access to high quality evidence-based pain care that reduces the burden of pain for individuals, families, and society. And it sounds great. You can read it. I think very good document. And I always ask this rhetorical question: has anybody heard about anything practical being done since 2017 to implement it? And I always get silence. Let's move forward. We got some support through Chief Medical Officer, and she was very warm and said, you know, you may not hear back from us right away, but, you know, keep on going. And it's good. We haven't heard back so far, but it's encouraging. Let's move forward. And, you know, we definitely need a change. The things are not necessarily getting better the way I see it. And I hope I didn't sound like too overly negative or complaining, but I do see, you know, people in danger. I do see, I do get letters from the coroner about, in May, we got about 9 overdose deaths in Cuyahoga County over 48 hours. And it just, and I see in front of me a lot of human tragedy. And honestly, I think it's getting worse. It's at the same time, Ohio is one of the 3 most challenging states to practice pain medicine for the reasons I discussed. And I think at some point, there should be some kind of switch from fear to cooperation. There should be like collective decision-making, exchange of knowledge rather than fear, finding better ways to deal with that. And it's Chinese wisdom. Those who say I can't change and those say I cannot are both right. Thank you so much.